Hello everyone. So today we will be discussing about ovarian tumors. Okay, so let's start it. First of all, we will be discussing about the clinical presentation of the patient with ovarian tumor. Okay, so just as all the tumor presents, they also presents with the mass or a space occupying lesion, and no needless to say that these masses are adnexal masses. Okay, now what peculiarities these adnexal masses has? These tumors, they are mostly cystic. Okay, these tumors, they are mostly cystic and they are very large. Okay, in routine practice we see ovarian tumors of 5 kg, 20 kg in once or twice a year. Okay, once or twice a year we do see ovarian tumor 5 kg, 20 kg, and in Guinness Book of Record they have also recorded the size of 100 plus kg tumor. Okay, so these tumors, they are very cystic and they are very large, and they are the largest tumor of the mankind. Okay, so one thing you keep in your mind, that larger the tumor is, lesser are its chances that it will be malignant. Because if that tumor would have been malignant rather than benign, then that tumor would have worst prognosis. Even when the tumor was small, the tumor would have bad prognosis, and patient would have expired even when its size was small. It is benign, that is why the tumor is growing and the whole of the body is compensating. Okay, okay, so now such a large tumor and body has to make that fluid content of that tumor, right? I told you that it is cystic, right? And the body has to make the fluid or the content of that tumor. So from where that content comes? Of course from our body, in the body whose the tumor is. So due to such a large content of the tumor, the patient suffers from hypoproteinemia, and the patient suffers from hypoproteinemia, and due to that hypoproteinemia, along with the ovarian tumor, the patient also has ascites and pleural effusion or hydrothorax, you can say. Okay, and ascites and hydrothorax. Okay, so these findings are also seen when a patient is suffering from ovarian tumor. Okay, on all these peculiarities of the ovarian tumor, question has been asked in August 2020, that in FMG, that during the laparotomy 60 years old woman, a mass is seen next to the uterus. So this is not a uterus mass, this is as this is a grayish color mass, and this is uterus. Okay, so you all know that color of the ovary is also grayish, so the answer to this question was ovarian carcinoma. Okay, now we will see in which two age groups we see this tumors. Most commonly we see it in post menopausal age group. Okay, we see it in post menopausal age, that is around 50 to 60 years. Less commonly we also see in young girls. Less commonly we also see in young girls. Okay, less commonly we also see in young girls. Okay, so what are the investigations? Now of course, when such a patient comes with such complaints, we will examine the patient, and on PA or PV we will find a mass, and that mass. So one question more was left: what would be the symptoms of the patient with such a large mass? Of course, the patient will have pain abdomen, and the patient will have abdominal distension and respiratory distress, because that is of such a large tumor, and the ascites along with it is going to affect the breathing, right? So the patient will also have respiratory distress depending on what is the size of the tumor. So investigations which we will go for is ultrasound to confirm our examination finding. We go for ultrasound. Okay, so now let's see on the ultrasound there are some features which suggest that the tumor is benign or tumor is malignant. Okay, so the features which suggest that tumor is malignant is that if in the tumor we have septate, the septate nature of the tumor indicates that there are papillary structures, and that to indicate that the tumor is cancerous. Another is irregular outline, and the solid nature of the tumor also indicates it is malignance. And the last but not the least is the multilocularity. Okay, so now let's see, this question was asked in INICT November 21. Para 2 live 1 uneventful postnatal patient is coming to you with and complaining of dull aching pain. On examination, findings are not given here. They have told that on ultrasound a 5 centimeter ovarian cyst was formed. So here you will keep in mind that small cyst, it is not always that whenever we are getting an adnexal mass it is due to the tumor. Okay, so hormonal disturbances, they also form cyst in the cystic adnexal masses. Okay, but these adnexal masses are very small, just as given in the question, 5 centimeter ovarian cyst. Now how do we treat this hormonal disturbance ovarian cyst? Okay, so these small ovarian cysts is we have to we as we know that these are small and these are not ovarian tumors if they are less than and equal to 5 centimeter. Okay, then we have to give combined oral contraceptive pills to cure that hormonal disturbance, and we have to must it is must that we have to ask the patient to do follow up after 4 or 3 months to see whether that cyst has got enlarged, or whether the cyst has not become tumorous. Okay, so if the cyst is less than 5 centimeter or equal to 5 centimeter, then combined oral contraceptive pills and follow up is the treatment. So here it is follow up. So, and if that cyst is more than 5 centimeter, if that cyst is more than 5 centimeter, then the excision is the treatment. Okay, then excision is the treatment. Okay, then such a big cyst more than 5 centimeter will not resolve by oral contraceptive. Okay, it is not that I'm telling you that more than 5 centimeter cyst cannot be due to hormonal disturbances. They can be due to hormonal disturbances, but it has been seen practically that more than 5 centimeter cysts, they are not cured by combined oral contraceptive, or simultaneously they don't get cured. We have to excise that cyst. Okay, so this was a question which was asked in FMG December 2020, that there in that there was a size of the cyst was 6 centimeter instead of 5 centimeter. They have given the size 6 centimeter, and answer to that question was laparoscopic cystectomy. Okay, laparoscopic cystectomy. Okay, now let's go to the what are the different types of the ovarian tumor. Now we have seen that a patient has come, a 55-year patient has female has come to us with the abdominal adnexal mass, and this mass is very large, and accompanied with that mass there is ascites and hydrothorax. Right, now what all are the different type of ovarian tumors we should know, so that we can send the tumor marker of that suspected tumor. Okay, we are not going to send all the tumor markers of the ovarian tumor. We will suspect that which tumor, we will interpret in our mind which tumor is this and which tumor marker has to be sent. Okay, so now let's see what are the different types of ovarian tumor and what are their tumor markers, so that before surgery, before removing that tumor, we come to know that which tumor this is, and that our finding, that interpretation will be confirmed by the tumor markers. Okay, and these tumor markers are quite often asked in exam. Please be focused. Okay, so let's start it. Ovarian tumors, they are of four types. First is the epithelial ovarian tumor. If the epithelium of the ovary, this if the epithelium of the ovary, it becomes tumorous, then it is known as the epithelial ovarian tumor. If the germ cell, the ovum, it becomes tumorous, then it is known as the germ cell tumor. If the follicle of the tumor becomes tumorous, then it is known as follicular cell tumor. You all know that follicle is the place where our ovum rests, where ovum is there. Ovum is inside the follicle, so follicle is the home of the tumor. So the if that follicle get tumorous, then it is known as the follicular cell tumor. Why this follicle is known as sex cord? Okay, so we all have studied in menstrual physiology that the follicle's granulosa cell, this outer layer of the follicle is known as the granulosa cell. Okay, this is known as the granulosa cell. The granulosa cell synthesizes estrogen when this follicle is stimulated by follicle stimulating hormone, right? This granulosa cell, it synthesizes estrogen, and this estrogen is responsible for all the feminine characteristic of the female. This estrogen makes the secondary sexual characteristic. This estrogen is responsible for menarche. So needless to say, a female is female due to this estrogen or this follicle. Okay, so that is why these follicles are also known as sex cord. Okay, okay, now fourth type of tumors are the metastatic tumors. What is metastatic tumor? It means that tumor was originally somewhere else. Due to the malignancy nature of that the tumor, the original tumor, this tumor has now spread to the ovary, and those tumors are known as metastatic tumors. Okay, so now let's study this question. They are saying that 37 years woman, unmarried, the woman is unmarried, on oral contraceptive pills, visits gynec for routine screening. Okay, for routine cancer screening, it should be, they have not mentioned, you will come to know later. The mother had CA breast at 55 years and sister had the CA breast at 40. What is your advice? Now please focus, this is the question of INI CT May 22. Okay, what is your advice? So this question is regarding the etiology of the ovarian cancer. Okay, so you should know that the ovarian cancer, their main etiology is BRCA mutation. Okay, if the BRCA1 or BRCA2, they undergo genetic mutation, and then the ovarian then the patient can suffer from four cancers, not only one, four cancers. Number one is of course ovarian cancer, breast cancer, endometrial cancer, and number four is colon cancer. So if any patient of ovarian mass is coming to you, then you are going to ask that patient whether your first degree or second degree relative are having any of these cancers or not. Okay, so suppose that any patient come to you with ovarian mass, so you're going to ask the familial history. If that patient has the inheritance of that BRCA gene mutation, then it's first degree relative or second degree relative, must be having one of these cancers. Okay, so when you are dealing with the history of the patient with an nexal tumors, then you are going to ask that whether there is any family history of ovarian cancer. Simultaneously you are going to ask whether there is any history of breast cancer, endometrial cancer, or colon cancer. Okay, so as you can see that here two relatives, close relatives are having CA breast. Her mother and her sister both are having CA breast. So there is high chances are there that this lady is having BRCA mutation. So answer to this question is genetic testing and BRCA mutation. So if this lady is having the BRCA mutation, high chances are there that this lady is will be suffering from this lady will be suffering from soon this lady will also be suffering from any of the four cancers. Okay, so let us study ovarian tumor etiology. Genetic mutation of BRCA1 and BRCA2. Okay, and then next is the familial predisposition, and you have also to ask the familial predisposition. If one first degree relatives, what are first degree, those who are in the close blood relation, mother, sister, daughter. Okay, if one first degree relative history is present, then the chances of having any of those four cancers are 12%. If two first degree relatives are having, as in the case of that this patient we discussed in the question, then the chance are that there are 40% chance. Okay, so this was the common etiology of all the four types of all the three types of ovarian tumors which we discussed. And now let's go to the specific etiology of the epithelial ovarian tumor. What is the specific etiology of the epithelial ovarian tumor? Okay, so now let's see. Epithelial ovarian tumor etiology, specific etiology. In addition to the BRCA mutation, epithelial ovarian tumors, they have these etiologies also. One concept you have to make if you want to understand the tumors etiology, one concept you have to make, that the all those factors which increase the basic functioning of that organ, okay, all that factors which increase the basic functioning of that cell, they increase the chance of the tumor formation. Okay, so all those organs which are increasing the basic functioning of the epithelium will increase the chance of the epithelial ovarian tumor. So let's see what is the function of the epithelium of the ovary. You all know once in a month the ovary ovulates. Then when this ovary ovulates, then the epithelium ruptures and the ova jumps from the ovary into the fallopian tube, right, during ovulation. Now all those factors which will increase ovulation will increase the function of the epithelium, and they will risk the patient to the epithelial ovarian cancer. Okay, so over functioning risk the patient to the epithelial ovarian tumors. Okay, so now let's see. More the ovary ovulates, more are the chances of the epithelial ovarian tumors. So what are the conditions in which a patient ovulates more? When the patient is nulliparous. During pregnancy, you know that the ovulation stops for 9 months, and later the ovulation stops for one more year due to the lactational amenorrhea and the contraceptives usually the patient takes for spacing. So one pregnancy means that the lady ovulation rest for at least 2 years. Okay, so if that patient is nulliparous, it means that the patient, that lady's ovulation has not rested. It is prones the patient to ovarian tumors. Okay, the other factors are early menarche. More early is the menarche, the ovulation starts early. okay, and or the late menopause. Late is the menopause, ovulation ends late, okay. And the last is the ovulation induction drugs. These ovulation induction drugs we use in ART, and in one cycle with the help of this ovulation drugs we are making 10 to 15 ovas to ovulate. So normally only one ova ovulates in 1 month, right? But if in ART, when we are going for IVF, we make the lady to make 15 eggs in 1 month. So you can see how the burden of ovulation increase, and this ovulation induction drugs they prone the patient for epithelial ovarian carcinoma. Okay. Okay. Next is epithelial ovarian cancers. There's epithelial ovarian tumors, their subtype. Two things you have to keep in your mind, that these are the tumors which you will find in 55 years, 65 years old lady. Okay, why? As we have discussed that its etiology is ovulation, increased ovulation than the normal lady, then you know that this ovulation will increase by the last of the age, 50 years, 55 years, right? Now in the young age the ovulation is less. So how epithelial ovarian cancer will occur at a young age? So epithelial ovarian cancer, if BRCA mutation is there, then it can occur at a young age. But if there is no BRCA mutation, then usually there is no BRCA mutation. So epithelial ovarian cancer occurs at later ages, at around 55 to 65 years, when the patient has suffered all those increased ovulation. Okay, and these are the most common of all. As you know that nulliparity is becoming in trend. This is a western culture which is also uh, being nulliparous is a western culture. So more is the female nulliparous, more are the females nulliparous, more is the epithelial ovarian tumor spreading. This is the most common of all. Okay, so questions are asked because there are 15 types of ovarian tumors. So question are asked, which ovarian tumor is common? So it is the epithelial ovarian tumor which is common. Okay, so now see something, you all know that the ovary or the ovary epithelium is in touch with different organs in the peritoneal cavity. It is in touch with fallopian tube, it is in touch with cervix, it is in touch with the bladder, it is in touch with the endometrium, right? So when that epithelial ovarian cell is becoming tumorous, is becoming neoplastic, now the nearby which organ growth factors has influenced that growth will decide what is the nature of the cystic fluid. Okay, okay, let me repeat it. Depending on which growth factors of the nearby organ are acting on that tumorous epithelium, accordingly will be the fluid of the ovarian tumor. Okay, so let's see, if the fallopian tube growth factors has influenced that epithelial cell which was becoming tumorous, then the fluid of that ovarian tumor will be serous, and then that tumor will be known as serous cyst adenoma. Okay, serous cyst adenoma. And as you all know, this fallopian tube is in quite close touch with the ovary, so most common of the all is the serous cyst adenoma. Okay, so questions are asked and has come in FMG also, which is the most common ovarian tumor. So the answer to it was serous cyst adenoma. You know that fallopian tube synthesize watery fluid, so the fluid of this serous cyst adenoma will be serous, watery in nature, and it is most common of all the ovarian tumors. Okay, so if you are suspecting in a 55 years old lady on the basis of ultrasound finding and examination that this lady is having serous cyst adenoma, then you are going to order CA125. The tumor marker of the epithelial ovarian tumor is CA125. If that lady is of the lady which we saw in the FMG August 2020 exam. Okay, let me come to the question here. Now you can see that if on the examination and on the ultrasound you come to know that this lady is having serous fluid and there was no cyst or anything else, then there are high chances that it is serous and it will be serous cyst adenoma. Most commonly they are benign, but as they are the most common, so most common malignancy is also the serous cyst adenoma. So among all the ovarian tumor, the most common malignancy is also serous adenoma. Usually they are benign, but as they are very common, so most common malignancy is also the serous cyst adenoma. Let's see the question. This is question which has been asked in FMG November 18. Most common ovarian malignancy. So the answer to this question was serous cyst adenoma. Okay, serous cyst adenoma. So now let's go to the other type. If cervix growth factors has influenced, and one thing was left here in the serous cyst adenoma, that semoma bodies is the histopathological finding of it. Semoma bodies, you have studied the semoma bodies other where other in other disease also. So those semoma bodies, when you are going to order CA125 in which you are suspecting epithelial ovarian tumor, and then you're going to operate that tumor and then you're going to send the tumor to histopath. So if semoma bodies are found, then it confirms that it is a serous cyst adenoma. Okay, the another tumor is the mucinous cyst adenoma. Here the epithelial ovarian tumors are influenced by the growth factors of the cervix, and the cyst, the fluid nature of this cyst is mucin. Okay, and now imagine one thing, this tumor was growing, getting large in size, is and the mucin was there, and what if this tumor ruptures? The whole of the mucin will now in the peritoneal cavity. Okay, so now the whole of the mucin, it will be assumed, who is examining the patient first time, that this peritoneum has made this mucin. Okay, so this will simulate, will be similar to the condition myxoma peritonei, right? It will look like as if that the peritoneum has made the that the peritoneum has made that mucin if it ruptures, right? So myxoma peritonei is originally found in carcinoma appendix. The patient of carcinoma appendix, in the patient, the peritoneum, it synthesizes large mucin. Okay, so but here the originally the tumor was ovarian, it has ruptured, so it will the findings will be similar to that of the carcinoma appendix where myxoma peritonei is there. Okay, so the condition which is similar to the myxoma peritonei is found here, and that is why it is known as pseudomyxoma peritonei. Okay, and question also have come in the past, very in the very previous year, I think 6 7 years back, they have, it has come that the true myxoma peritonei is finding. So the answer was carcinoma appendix, and the pseudomyxoma peritonei is found in mucinous cyst adenoma if that mucinous cyst adenoma ruptures in the peritoneal cavity. Okay, now another tumor of the epithelial, another subtype of the epithelial ovarian tumor is the Branner's tumor. Here the tumor is here the epithelial tumorous cells, they are influenced by the bladder, and when we after dissecting this tumor, when we after doing the surgery removing this tumor, when we send this tumor for the histopath, then as in the bladder transitional cells are found, in the similar way here also transitional epithelium cells are found. Okay, and this tumor is also associated with pseudomic syndrome. Soon, after few minutes, we will discuss what is the pseudomic syndrome. Okay, the another subtype tumors are endometrioid tumor and the clear cell tumor. And the clear cell tumor are asked in exam is of which subtype. You can see here in the question is this: according to WHO, clear cell tumor of the ovary belongs to, so the answer was epithelial ovarian tumor. Okay, next is the germ cell tumors and their tumor markers. Okay, so you know that all of you know that uh, the germ cell is the ovum. When it fertilizes with sperms, then it makes, yes, then it makes the whole of the fetus. Along with fetus, it also makes a yolk sac, and along with yolk sac, it also makes placenta. So a germ cell makes three things. What are those three things? Embryo, yolk sac, and placenta. To understand the subtypes of the germ cell tumor, we are going to divide the germ cell hypothetically into three parts. You can see here down in the slide, I have divided the germ cell into three parts: the part of the germ cell which is making embryo, the part of the germ cell which is making yolk sac, and the part of the germ cell which is making placenta. Now if this part which is, this part which is upper part which is making, was making the embryo, suppose it only if this part gets tumorous, then in the tumor we are going to see the different parts of the embryo, and that is what we see in the dermoid cyst or teratoma. So what is dermoid cyst or teratoma? First of all, it is a subtype of germ cell tumor. Okay, and in the dermoid cyst we see the we can see all the three germ cell derivatives. Okay, this, you can see, this is the cross section of the dermoid cyst. Here are seen, you all have seen in this your pathology labs. Hairs are there, and then teeth can also be seen, thyroid tissues can also be seen. So all the three germ cell layer derivatives are there. That was a question in FMG December 21. Which ovarian tumor has all the three germ cell layer? So the answer to this was एक मिनट, dermoid cyst. Okay, dermoid cyst. So what is the name of the tumor which in which the embryonal part gets malignant? Dermoid cyst or teratoma. If this tumor is benign, then it is known as benign teratoma, and if this tumor becomes malignant, then it is malignant teratoma. It is, this tumor is the most common of all the germ cell tumors. Okay, and usually it is benign. Okay, okay, so the dermoid cyst or teratoma, we at our surgical centers are every month we are operating one dermoid cyst. It is such a common, and rarely in my 10 years of experience, rarely we get the malignant. I haven't get any malignancy in this. Okay, so just it is there, and there is no tumor marker for this dermoid cyst. Okay, when we on the ultrasound, it is quite clearly written dermoid cyst, because in the ultrasound the radiologist appreciates this hair like structures and all these things, so it writes and we operate, and usually the usually it comes out to be benign. Always it comes out to be benign. In my 10 years of experience, of clinical experience, I have never seen any tumor which has come out to be malignant. Yes, it gets malignant, but it is very rare, and is the most common germ cell tumor. As I already told you, we every month we operate this dermoid cyst, so it's the most common germ cell tumor. Okay, Okay. Epithelial ovarian tumors are much more common than germ cell tumor, but among the germ cell tumor subtypes, this dermoid cyst is much more common. Okay, okay. Now, if this yolk sac part it gets tumor, then in the yolk sac, sorry, then the York-sac tumor is formed. Then the York-sac tumor is formed, and the tumor, another name is endodermal cell. Why its name is endodermal sinus tumor? Because the York-sac, as you all know, comes from and the tumor marker of the York-sac is alpha fetoprotein. Alpha fetoprotein, it gets elevated. Okay, and as you all know that the yolk sac serve as a function of the liver or as a function of nutrition, so you can learn it that as the yolk sac is serving the function of nutrition, so that is why something proteinaceous is getting increased, and that is alpha fetoprotein. Okay, and the histopath finding which we get after dissecting that yolk sac tumor is, let me show you the histopath findings are the Schuller Duval bodies is, and I will tell you why it is known as endodermal sinus tumor. What are Schuller Duval bodies? This is a magnified image of the histopath finding of the yolk sac tumor. See, this is the blood vessel. This is the blood vessel, pinkish color blood vessels. Then cells are arranged around it. Okay, so these are the neoplastic cells, and around the cells, here there are the sinuses, as you can see. These are the sinuses. So what is the arrangement? In the center there is blood vessel, then there is cell, and then there are sinuses. So this structure is known as Schuller Duval bodies, and this was a question which was asked in INICT May 2022, and it is quite asked commonly in exam. Histopath image, this the that histopath image was given, that the histopath image of is that the histopath image which I showed you is seen in which tumor. So answer to that was York sac tumor. Okay, the another name is endodermal sinus tumor, because here the sinuses are seen in its sinuses are seen around the blood vessel, and it is known as York sac tumor. Okay, okay. Now let's go to the our slide. The third part, the placenta part, was left. If the placenta part becomes tumorous, then it is known as the non-gestational trophoblastic neoplasia, and needless to say that the tumor marker of it is HCG. You all know that. And the if the whole of this germ cell, this whole of the germ cell, not any part, if whole of this germ cell it becomes tumorous, then it is known as the embryonal carcinoma, and the tumor marker which are raised in this is alpha fetoprotein, HCG, both are raised. Now because the placental part is also increasing and the yolk sac part is also increasing, just give me 1 minute. Okay, so I'm back here. Okay, so you can see that in the embryonal carcinoma, because whole of the germ cell is becoming tumorous, that is why that is why both the tumor markers of the embryonal of the sorry the yolk sac tumor and the placenta tumor, both the tumor markers they increase. Okay, and now the last type of the germ cell tumor, which is the primordial germ cell. tumor. Okay, now the last type of the germ cell tumor, the primordial germ cell tumor. Now here the germ cell is not becoming tumorous, the primordial germ cell is becoming tumorous, and this tumor is known as the dysgerminoma. It is same to this, it is similar in nature to the seminoma, which you all have discussed in the, which you all of you have seen in the surgery. Okay, seminoma you all have read in surgery. So it is same here also, the primordial germ cell, not the germ cell, primordial germ cell is becoming tumorous, and this tumor is known as dysgerminoma. And the histopath finding of this tumor is similar to that of the seminoma histopath, and this is the most common germ cell tumor to become malignant. Okay, this is the most common germ cell to become malignant. And the tumor marker of this will not be alpha fetoprotein, not will be it, not it will not be HCG. Tumor marker here will be LDH, it will be LDH. Okay, so the tumor marker of dysgerminoma is LDH. Okay, so and this histopath finding will be same as that of the seminoma, large cells with large nucleus and lymphocytic infiltration. Okay, so I hope now you all the tumor markers are clear. If you are and this germ cell tumors, they are found in young age, around 25 years they are found. These are found in young girls. Okay, so this is a small slide to see which tumor markers you will send. If you are if you are getting a lady of 55 years to 65 years, then you will order, then you will suspect that this is a epithelial ovarian tumor. So you are not going to send all the germ cell tumor markers. Okay, then you will send a CA125. Okay, here we have sent CA125. Okay, if a young girl comes to you with NXL mass, then you will send an LDH or alkaline phosphatase. If you are suspecting dysgerminoma, if you are suspecting any non-gestational trophoblastic diseases, then you will send HCG. If you are suspecting York sac tumor, then you will send alpha fetoprotein. And if you are suspecting embryonal carcinoma, then you will suspect alpha fetoprotein and HCG. Okay, now let's say all these tumors, you are not suspecting anything, you're just a lady with an excel mass at 25 years has come, then you will send these three tumor markers: LDH, alpha fetoprotein and HCG. Okay, if LDH is raised, then this germinoma is there. If only alpha photoprotein is raised, then the tumor is York sac tumor. If HCG is raised, then it is non-gestational trophoblastic diseases. If both alpha fetoprotein and HCG are raised, then it is embryonal carcinoma. Okay, now the last tumor marker and the last subtype which is left is the inhibin B, which soon we are going to discuss. Okay, now this is a question from NEET PG 2016. Very beautifully they have given the clinical presentation of the patient. 55 years old lady, it present with distension, bleeding, pelvic pain and respiratory distress. Okay, and on clinical examination reveals features of ascites. Distension is there, okay, in a 55 years old lady, and respiratory distress is there. It means that there was a large mass, and ovarian mass. So because and there is also ascites, and last confirmatory feature that CA125 is elevated. If CA125 is elevated, then of course it is going to be the CA ovary. And which tumor marker it is, which tumor it is? Epithelial ovarian tumor, and most common among them is serous cyst adenoma. Serous cyst adenoma. Okay, now let's move to the Last topic of the ovarian tumor, which is the sex cord or the follicular cell tumor. Depending on, you all know that there are two type of cells, the granulosa cells and the theca cells. If granulosa cell become tumorous, then its tumor marker is inhibin B and estrogen, because as you all know, estrogen is raised in much in another diseases also, and it is non-specific. So only inhibin B is a tumor marker of the granulosa cell tumor. Due to the increased estrogen synthesized by the granulosa cell, if that female has not attained menarche, then that female will suffer from precocious puberty. And if that female has attained menarche, then that female will have sudden menorrhagia. Okay, if any patient with adnexal mass is coming to you with these symptoms, that there is adnexal mass and there is a sudden precocious puberty and there is a sudden menorrhagia, then what you are going to do? Then you are going to get the tumor marker inhibin B done to rule out the granulosa cell tumor. Okay, the another tumor which you see is the subtype of follicular cell tumor is the thecoma tumor. Okay, the third type is that Sertoli Leydig cell tumor. The remnants of the Sertoli Leydig cells are there. They get tumorous, and now these Sertoli Leydig cell, as in the males, they will synthesize testosterones, and now the female will become male due to the testosterone. And these tumors, as they change the gender of that person, they are known as arenoblastoma. Now the last type is the Meek syndrome or the fibroma. Now see, as I already told you, that the ovarian tumors, they are associated with fibroma, and when it is the fibrous cells, they become tumorous, then it is known as fibroma. And you know that the fibrous tissue, large protein is will be consumed to make that fibroma. Now because body large protein will be consumed to make that fibroma, then that lady who is having fibroma will suffer from ascites and hydrothorax, as explained earlier in the first slide itself. Okay, so question has come in FMG whether in Meek syndrome there is benign fibroma or malignant. So answer is benign, because if it would have been malignant, it would have patient would have suffered from the worst prognosis before coming to the ascites. It is only the benign tumors which get large in size is, and the body keep on synthesizing fibers and consumes the proteins. Okay, so first of all, this syndrome of ovarian tumor and ascites and hydrothorax was found in fibroma, so it is known by, and it was found by Meek, so it is known as Meek syndrome. If any other ovarian tumor is associated with ascites and hydrothorax, then it is known as pseudo Meek syndrome. And most common ovarian tumor in which ascites and hydrothorax is found is the Brenner's tumor. Again, all these both tumors, they are solid and more protein is consumed, so ascites and hydrothorax come at the early stage. Okay, next is the Meek syndrome is, so this was a question of FMG December 21. So it is benign fibroma plus ascites and hydrothorax. Pseudo-Meek syndrome, we have not got the question of pseudo-Meek syndrome, but it can come that in the pseudo-Meek syndrome there is yes, in the pseudo-Meek syndrome there is it is associated most commonly with Brenner's tumor. Okay, now see, this was the question of INICT November 21, that York sac tumor, the marker is alpha fetoprotein. In the choriocarcinoma or non-gestational trophoblastic disease, the tumor marker is HCG. Epithelial cell tumor, the tumor marker is CA125. The granulosa cell tumor, it is the LDH. And uh, here it will be, sorry, in the granulosa cell tumor it is inhibin B, and in the dysgerminoma it is LDH. Okay, so this is the match. And now these are the call Exner body, and these are the histopath finding of, these are the histopath finding of, yes anyone, and granulosa cell tumor. So I have make you to learn only two tumors histopath finding granulosa cell tumor. Okay, so these are the call Exner bodies. One I make you to learn Schuller Deville body, and the another is a call Exner bodies. Only two histopath finding, but tumor markers you have to learn all. What is the call Exner body? Here in center there is blood vessel, then an empty space, and then cells are arranged. So it stimulate just like flower. Okay, so these flowers, as you know that in flower also in center there is empty space, and then its petals or patiyan are there. Okay, so in the similar way to the pathologist it looks like flower. You can see that these are the cell, in the center there is empty space. I just want to tell you here that in the Schuller Duval bodies the empty space was here. Okay, so here I would like to tell you, if you get confused in learning, we also get confused in learning which tumor marker is of which histopath finding is of which. See, Schuller Duval bodies is of endodermal sinus tumor or York sac tumor, and Call Exner bodies is of granulosa cell tumor. Okay, so it is starting with letter alphabet S, and this alphabet S is the second alphabet here. Okay, call Exner body C, and it is also the granulosa cell C tumor. So you can see S of Schuller is found here in the name of the tumor, endodermal cell and York sac tumor, and call Exner bodies are C is in the granulosa cell tumor. This is how we learn in the practice. Even we also forget. Okay, so Schuller Duval bodies is find in this has question in INICT May 22. It is find in York sac tumor. Matching was there in the INICT exam. Syncytiotrophoblast is found in choriocarcinoma. Large cell with prominent nuclei and lymphocyte, it is found in dysgerminoma. This is correct. And cartilage, bone and neurons are found in teratoma. Next is the metastatic tumor of the ovary. Now, what if the tumor from another organ has spread to the ovary? Then this is known as the metastatic tumor of the ovary. Most commonly, stomach cancer or carcinoma stomach spread. So this is also asked, when carcinoma stomach it spread to the ovary, then it is known as Krukenberg tumor. Okay, name is Krukenberg. One more you have to remember the name. One more name you have to remember. Okay, it is the Krukenberg tumor. Okay, so it is known as the Krukenberg tumor, and the peculiar finding of on histopath here is signet ring cell. Empty cells are found, just like ring. It is known as signet ring cell. Okay, ovarian cancer staging by surgery. To when we are removing any tumor, what if now the lady has come with the adnexal mass, we have removed, we have ordered the tumor marker, we have get the tumor marker done as per our suspicion, and now we have to remove that tumor. We have to do surgical staging. So 4 steps are done in ovarian tumor staging. What are they? We have to remove that tumor, and we have to send it for biopsy to see whether Schuller Duval bodies are coming, or Call Exner body, or it is a seminoma type, right? And then other than removing the tumor and sending it to biopsy, we will also get the peritoneal washing or that ascitic fluid. We will also send those peritoneal washing, or if ascitic fluid is present we will send that, and we will also get the biopsy done for that. And then optimal demulking. What does optimal demulking means? That wherever we are seeing any ulcerative growth inside the abdomen, inside the peritoneal cavity, we are going to send that growth also. We are also going to do a retroperitoneal lymph node biopsy. Okay, so these are the four steps which we will do while we are removing the ovarian tumor. Okay, these four steps are must. Okay, because now we are not going to do second surgery. Okay, this was the question which was asked in FMG December 20. I have already told you that this was a simple small 6 into 6 centimeter. So the answer was lap cystectomy. Ovarian cancer staging are already discussed in the video. You know that all the cancer staging in one go. Okay, all the genital cancers were discussed in one go. In that video you can go and you can learn how we will remember the ovarian cancer staging. Just in a short, I will tell you, if the cancer is limited to ovary, it is stage 1. If it is the cancer is limited to pelvic cavity along with the ovary, it is stage 2. If it is gone into the abdominal cavity, it is stage 3. And if it is gone rest anywhere in the body, it is known as the stage 4. The last slide now we are having on the treatment of the ovarian cancer is that the ovarian cancerous cells, they are they are resistant all the ovarian cancer except dysgerminoma. ठीक है, they are resistant to, yes, as radiotherapy. Ovary is in the whole body, ovary is the most radiosensitive organ, but ovarian cancers, they are the radio resistant. Okay, they are the radio resistant except this germinoma. So here the treatment is chemotherapy, and that chemotherapy is platinum based. Okay, and that chemotherapy is platinum based. Okay, so ovary is the most radiosensitive organ, but ovary cancer, when that ovaries cell they get cancerous, they becomes a radiotherapy resistant, and we use chemotherapy to treat it. Now the last slide has come from the FMG December 2020. All is done in CA ovary except debulking surgery. We have read, we do it, and IV chemotherapy we do it. Yeah, debulking surgery we do it. IV chemotherapy, yes, chemotherapy is the treatment because already we have done the surgery. Then left is the chemotherapy. Intraperitoneal chemotherapy, yes, we do it. Radiotherapy, this we don't do it because the ovarian tumors, they are radio resistant. Okay, thank you for being patient. It's such a large topic. See you soon in the next video of endometrial carcinoma.